So today we're going to be talking about recognizing eating disorders in the context of mental health treatment. And like was introduced, I am from LAVO, a mind care company. So LAVO means to lift, hold up, and make lighter. And that's really our mission at LAVO, is helping our patients to feel lighter, and to really help navigate them through their mental health journey. So that's our philosophy there. So we do have 4 locations currently across the state. Our newest location is Orem, and we are just across from Aspen Grove. So we're located there, and we plan to open a location in St. George next year. So we're excited about our expansion and kind of what we do. So we provide comprehensive evaluation of mental health symptoms, along with diagnosis, prescription, medication management, and we do offer non-medication resources for individuals in all age groups. We do focus on that biopsychosocial model and treating the whole person. So that's a little bit about LAVO. Our objectives today is to understand the overlap between eating disorders and other mental health conditions, and also to be able to learn how to identify key warning signs with eating disorders. And we'll also be discussing different screening tools and collaborative care approaches. So just an introduction on the prevalence of eating disorders in mental health care. There was a study cited in the American Psychiatric Association. They have practice guidelines that found that for individuals who were referred to a community-based mental health service for anxiety or depression, showed that 18.5% of those individuals screened positive for eating problems, and 7.3% of them met criteria for a DSM-4 eating disorder diagnosis. So it is prevalent, and most likely you will come across it when you are treating mental health. So it is something to be aware of. So most of the time, you're not going to be treating someone who just has an eating disorder. There's a lot of comorbidities with other psychiatric disorders, mood disorders, anxiety disorders, OCD, substance use, including alcohol use or stimulant use disorders. But the most common comorbidities with eating disorders is going to be anxiety and depression. So just something to be aware of there. So because of the prevalence of eating disorders in mental health, it is important to be able to identify and treat those eating disorders promptly. Because we know that if they're detected earlier on, that there is better outcomes for the patient, they have a more rapid recovery, and we know that a delayed diagnosis is more common, and that is associated with worse prognosis. So if we can catch it early on, we know that they have better outcomes and are able to recover quicker than those that have had it for a while when it's undetected. So one of the ways that we can identify those early on is by doing a screening for eating disorders and do it systematically while doing a psychiatric evaluation. If we do that, we know that we can detect those eating disorder issues early on, and because eating disorders are frequently missed and under-recognized, we might miss some of those obvious physical symptoms if we didn't specifically screen for an eating disorder. And then if we are able to catch it early on, we're able to, work in a multidisciplinary team, getting everyone involved that needs to be involved to treat the eating disorder, to reduce severe medical complications that are common with eating disorders and long-term disability. So screening and early diagnosis is really key, given the high prevalence of eating disorders in psychiatric populations and because of their frequent comorbidities with mood and anxiety. So different screenings and initial assessment information. So again, recommended to have universal screening recommendations. Ask all patients about eating disorder symptoms during a psychiatric evaluation. There's different screening tools out there. They have the SCOFF questionnaire, EDS-PC, and the EAT-26. At LAVO, we use the EAT-26. So I'm more familiar with that one, and I really like that one because it's pretty comprehensive in identifying a patient's perception of their bodies and themselves, and it goes over their eating habits. So it's pretty comprehensive, and it's a good screening tool to use. And it's definitely helped in our practice to help identify patients that may have gone undetected in their eating disorder. So some specific information and interview questions to help with getting a history in those initial psych evaluations, especially in our children and adolescents where we want to catch those eating disorders early on, is to gather weight history. We want to know their highest and lowest weight, when that was, how they feel about their body and their body image. We want to know what their diet is like, what the history is on what they've been eating, exercise habits, other eating disorder behaviors like binging or purging, family history of eating disorders, go over their review of symptoms, and a complete psychosocial history where we get information about their home life, education, what kind of activities they engage in, any drug use, depression, suicide, or sexual identity. So some of the common eating disorders that you will come across: anorexia nervosa, bulimia nervosa, binge eating disorder. And another one that we're seeing more often is avoidant restrictive food intake disorder. So that one is becoming more prevalent, and you'll see that a lot in patients that are on the spectrum, autism spectrum disorder. So some of those risk factors for eating disorders, again, the psychiatric comorbidities like depression, anxiety, OCD, and substance use, trauma. If there's someone struggling with perfectionism, that's a really common risk factor. Of course, social or cultural pressures and demographic considerations. Although we know that eating disorders do not discriminate. Anyone can have an eating disorder, so something to keep in mind. But we are seeing more prevalent rates of eating disorders in our transgender and sexual minority youth groups and young adults. And they are at higher risk for the eating disorders in psychiatric populations. So it is important to be familiar with the DSM-5 criteria for eating disorders, and we'll go over that a little bit later on. But it is important to kind of familiarize yourself with those. Looking for behavioral signs, is someone engaging in restrictive eating, binging, purging, excessive exercise, food avoidance? Are they preoccupied with how they look, with their weight? Those are some signs to watch out for. And then we have physical signs like weight changes, bradycardia, hypotension, hypothermia, dental erosions, lanugo or amenorrhea. And then laboratory and medical assessment findings. So you want to get a CBC, a metabolic panel, an ECG testing hormones and bone density is indicated there. So just kind of a general overview and the characteristics of the different eating disorders that are most common. So we've got anorexia nervosa. Intense fear of gaining weight will lead to that severe food restriction. It can also involve excessive exercise. You can have purging as well. But overall, this would cause malnutrition, osteoporosis, and it can be fatal. And then we have the avoidant restrictive food intake disorder. So again, this is avoiding food due to sensory issues. Someone who's a very picky eater, you could say, and this leads to a significant weight loss or nutritional deficiencies. And we'll find that it's more common in children and adolescents. Bulimia nervosa. So characteristics of this would include the binge eating following by purging. Could be purging by vomiting, excessive exercise, or misusing laxatives or diuretics, things like that. So this would lead to dehydration, electrolyte imbalances, and digestive issues. And this can also be fatal as well, and pretty dangerous. Binge eating disorder, it's eating large amounts of food quickly without compensatory behaviors. Of course, these things can lead to obesity, type 2 diabetes, hypertension, and you'll find usually they have a lot of psychological distress, feeling a lot of guilt and shame after behaviors. And then we've got other specified feeding or eating disorders. So this is kind of the atypical cases where behaviors can cause distress, but they don't necessarily fit other categories. So symptoms vary there. It could be kind of an atypical anorexia or bulimia. So this chart is a good representation of some common medical and physical complications that are associated with anorexia versus bulimia. So in anorexia, they're going to be usually a low weight, have bradycardia, hypotension. They'll also have some orthostasis or hypothermia. And then with skin, they can grow that fine hair called lanugo. If they're losing hair, their hair's thinning, or the keratonemia. Also, it affects the heart. They'll have a prolonged QTC. You'll want to monitor for edema. They're going to have delayed gastric emptying, constipation. They're going to have neutropenia, normochromic anemia, and then it's not uncommon for them to have hypoglycemia, hyponatremia, hypercholesterolemia, elevated liver function tests, and then it also affects the hormones there. So they'll be low in their hormones, have elevated cortisol. Most of the time, they're going to have amenorrhea and decreased bone density. So it is important to have them complete a DEXA scan to monitor for that. So you can see how many body systems these affect. Bulimia, more common to be at a normal weight or overweight or obese. There's a thing called Russell-Stein that you can look for, basically a callus on the hand that forms when they're engaging in self-induced vomiting. You'll see, some dental issues, salivary gland hypertrophy. So they're kind of going to have swollen glands there. Elevated serum salivary amylase, hypokalemia, hyponatremia, hypochloremia. They can also have, irregular periods or amenorrhea. So both are very dangerous, involve a lot of body systems, things to look out for. There are some medical mimics out there to be aware of when treating eating disorders. So thyroid disease and eating disorders, both patients could present with weight loss, fatigue, or mood changes, GI symptoms, changes in their heart rate, and a lot of physical findings for thyroid disease and eating disorders include that dry skin, hair loss, cold intolerance. Both of those, are common. And then sometimes you'll see patients that have restrictive eating disorders develop euthyroid 6 syndrome, where they have low T, a normal or low T4, normal or low TSH, and can resemble that hypothyroidism, but it's an adaptive response and doesn't require hormone replacement, thyroid hormone replacement. So something to be aware of, if they haven't had a history of thyroid disease in the past, getting a thorough history and monitoring those kind of labs frequently in their treatment is important to help distinguish between that. GI disorders are also very common and can mimic eating disorders. And of course, some of eating disorders can cause GI disorders, but those common symptoms include weight loss, abdominal pain, nausea, bloating, food avoidance. So GI disorders like IBS, celiac disease, those, can mimic the symptoms of eating disorders like, someone that's restrictively eating, vomiting, changes in appetite or weight. So one way that we can help distinguish between like a GI disorder and an eating disorder is just the pathology like inflammation, malabsorption, the temporal relationship between GI symptoms and changes in eating behaviors. And then, of course, if GI symptoms persist, as nutritional rehabilitation takes place, those are most likely going to resolve and improve, whereas those organic diseases are going to continue. And then this chart can kind of show you, again, the different behaviors and things to look out for. in the different most common eating disorders, and then kind of what treatment approaches are beneficial. So again, a thorough history and lab results are going to be important for all of these. We've got the comorbidities and common substance use disorders related to binge eating. So we've got the different eating disorders, characteristics of those, and then just some treatment considerations. How long have they been struggling with the eating disorder? What's the severity of their weight disturbance? Do they have access to treatment? What's their treatment history? Are parents involved? Are they suicidal? What medical complications are occurring? So anorexia focus would mostly be on weight restoration and family-based therapy approaches, especially for adolescents. Studies haven't shown a ton of benefit or limited benefit. And as far as bulimia, CBT, and SSRIs, and we have fluoxetine is FDA approved for bulimia. And then binge eating disorder, again, CBT and antidepressants, and Vyvanse is also FDA approved. And then for ARFID, a lot of that is going to be food exposures, behavioral treatment to help increase the variety and amount of foods eaten there. So another thing to monitor when you're treating eating disorders is how it impairs their psychosocial. So typically someone with an eating disorder is going to become increasingly isolated. They're going to stop hanging out with friends or stop going to family gatherings, things like that. And you'll also see psychiatric comorbidities that are worsening. They have significant distress, impaired relationships, and reduced quality of life. And a lot of eating disorder patients, have that perfectionism. They're going to, have straight A's, things like that. But then you're going to see that kind of decline as things get worse in the eating disorder. It can cause a lot of strain on the family, create a lot of tension in those relationships. And so family therapy is really important. And then because of the comorbidities, you'll see those become more frequent, and those comorbidities can increase that psychosocial impairment. So some things to keep in mind when you're questioning whether or not to refer for a specialized treatment or evaluation of an eating disorder is, what medical complications are going on. If the patient has some safety concerns, if they're suicidal, they self-harm, or they're psychotic. And then, if they're in outpatient treatment, but they're just getting worse, it doesn't seem to be effective. And I think the main thing too to realize with eating disorders is you can't treat them on your own. It really does take a team, and that collaborative care. They need care in psychiatry, psychology, nutrition, medication management, medical monitoring. So it really does take a whole team of people to treat eating disorders. And we know that coordinated care can reduce mortality, helps with the weight restoration process if that's part of the treatment, can help them psychologically, and they can better manage those comorbid conditions. So here's another chart that is helpful in whether or not a patient needs more specialized eating disorder treatment. So again, that lack of improvement with outpatient treatment. Do they have an elevated risk of suicide? Do they have access to outpatient treatment? What percentage of weight loss has occurred 10% or more in 6 months, or greater than 20 in 12 months? If their BMI is below 15, that's pretty low. I would say even a larger BMI than that would be like 16 is like inpatient treatment. Temperature 36 degrees Celsius, so that's just under 97 degrees Fahrenheit. Bradycardia, if it's below 50 beats per minute. If their systolic blood pressure reading is less than 90, if they have an orthostatic change greater than 20 in their sitting and standing blood pressures, if their QTC is prolonged greater than 450, blood sugar less than 60, sodium less than 130, potassium less than 3, phosphate less than 2, magnesium less than 1.5. So those are some parameters that would they would need, inpatient medical stabilization. So here's some references. I'll stop screen sharing. If anyone has any questions, now is the time.
It looks like we do have a question in the chat. I see someone asked, does the EAT-26 have an age range?
I'm not aware of an age range on that. We use it for all of our patients, so I don't think it does, but I'm not 100% sure if there's a specific age limit.
Okay, great. Any other questions before we move on? You can either drop them in the chat or just unmute and ask them. Looks like we got a couple here coming in. Is overeating the same as binge eating disorder?
I think it depends on, if you look at binge eating, are they feeling out of control? I think that's the key, is if they're feeling out of control with the binging and they don't have control over that. Overeating, I probably would say no, but I think it just depends on the level of control that the patient feels, is what I would say.
Great. And here's another question. What treatment modalities are most often used to treat eating disorders? And what is the best support a therapist can offer without any training in treating eating disorders?
So I think the most common we see, of course, the family therapy with adolescents. CBT and DBT are probably the most often used modalities, and we're seeing, the most benefit with those two, especially CBT. And let's see, what is the incidence of eating disorders on Latino populations? I don't know specific numbers of that, but again, we used to think eating disorders, it just affects, young, wealthy, white females. But we know that it's definitely prevalent in all people. Anyone is at risk. So it's definitely there in the Latino population, but I'm not specifically sure on the incidence compared to other populations.
Great. Any other questions before we move on?
Okay, it looks like there's another one. Based on statistics, is there a specific age range that is most vulnerable? So young adults are probably, and I think also because they're stressing on identifying them early on. So probably ages like 13 to 26 are probably the most at risk. And let's see, can you speak on some on how these eating disorders tend to go unrecognized in males? And is it just the stigma, or do you find clinicians don't address it with males? I think it's probably both. I think that it's becoming more prevalent in males. And so we're more aware and trying to assess that more with males. But I do think that we're overcoming a stigma with that. And again, thinking primarily that eating disorders were once just for young females. So I think it's a little bit of both the stigma and, we're just not screening it and addressing it with our male population as much as females. Yes, and diabetes. So that you can call that like diabulimia. So that's a comorbidity with eating disorders, manipulating insulin, and things like that is a behavior that can be an eating disorder, and it can complicate the diabetes. So it's definitely can be a problem with eating disorders and issues with that. Let's see, could eating disorders increase chemical changes in the brain and trigger other mental health diagnoses such as schizophrenia or depression? And I would say yes, because we know that the body requires energy to create those neurotransmitters. And when, we're malnourished, our body isn't going to be making those neurotransmitters as well. And so I think there could be, I think it would be possible. Depression for sure. I don't know so much about schizophrenia, but I definitely think that it would increase chemical changes in the brain when you're malnourished and you're not able to, you don't have the energy to create those those chemicals. So let's see, and one more. Is there something clinicians should be paying attention to when making referrals for eating disorder clinics and therapists? So a couple of things that I think are important in making referrals is if they believe in a health at every size. And I like the intuitive eating approach as well. I think that those are a couple of things to keep in mind if they treat based on those principles. I think that's a good indication that they have good experience in that. How can we as counselors assist patients in recognizing obesity when they seem unaware of the dangers and the primary care physician does not address the situation? So again, health at every size, but obviously they're more at risk for medical complications with the obesity. And I think an assessment, an eating disorder assessment like we talked about, or a screening could be helpful in a patient that's obese, and recognizing, that maybe their eating behaviors are leading to that there could be a problem there, and just helping them bring awareness to that. But it is kind of a tender topic to bring up with the patient, but maybe starting with that and just like a screening, and seeing what behaviors could be underlying, that's causing obesity would be something to consider. Any other questions? So do you utilize different techniques for patients who have undergone bariatric surgery and continue to have food struggles? So it is, I think one thing that you would run into with that is they would have to have kind of a specialized diet that would allow them to get the nutrition they need. So more frequent but smaller meals. But pretty similar treatment, I think. But I know you would have to have kind of some different dietary expectations if they've undergone bariatric surgery, if that helps answer your question. Any other, what is the tip on how best to address sensory issues? So really that's going to be exposure therapy, with different foods, I think. And, finding a dietitian that, has familiarity with ARFID, or, if someone who has an eating disorder as well as sensory issues, that would be key in helping them expose themselves to those different textures and flavors that they have issues with, and exposing them to that in a controlled way. I think that's probably the best tip on how to address that. And you're welcome. Any other questions?
Here we have a question that came into the chat. What about clients who may have health issues such as cyclical vomiting? Are you able to address some of that type of diagnosis?
Yeah, that's definitely in the realm of eating disorder. It would be probably similar to bulimia. People can, cyclical vomiting. So definitely, there's ways we can address that type of thing. Yeah.
Yeah, lots of great feedback.
Yeah, thank you so much.
Any other questions for Micquelle? Anyone have a question they're dying to ask? And you can go ahead and unmute yourself too if you wanted to just jump in and ask it as well.
No question, but just want to say thank you so much. These little things that we do are so insightful and so supportive. You would never know how important it is just to hear somebody else talk about the stuff that we struggle with as counselors. So I can't thank you enough for the stuff you've talked about today here. And too, on these great CEU things. Thank you so much. But this one was exceptional. Thank you. Real great insight. New stuff for me.
Thank you so much. I'm glad that you've learned something.
Thank you. And thank you so much, Joseph, for all of this that you do for us.
Oh, thank you, Pamela. I appreciate that. You're very kind.
There was one more question, Micquelle, if you don't mind, that kind of piqued my interest,
Oh, yeah.
and that is what's the link with eating disorders and postpartum?
Well, I think, postpartum, there's a lot of changes to the body, and that can be a trigger for someone, um, that it triggers them to become more, maybe negative view of their body, which could lead to an eating disorder. And then, there's hormonal changes with postpartum too that could lead to, more anxiety or depression, and um, which could also lead to an eating disorder. So I think there's different factors there. Just body changes, hormonal changes, can be a trigger for that, for sure.
Thank you.
Yep.
Again, thank you everyone for your time. And Micquelle, thank you so much for this presentation. It was very informative. And as you can see from the positive feedback, it sounds like it was informative for a lot of us.
Good. Thank you so much for having me.
Great. Well, thanks again, everyone, and enjoy the rest of your week.
Thank
Thanks,
you.
Joseph.
Thank you, Ben.